трансляції. В регіонах, де ми перебуваємо зараз, триває повітряна тривога, тож ми вітаємо вас із коридору або з інших захищених приміщень. Сьогодні ми проведемо чергову онлайн-зустріч із нашими сирійськими колегами. Це лікарі Сирійської академії медичних наук та організації екстреної медичної допомоги, які зголосилися поділитися своїм досвідом. Попередні тренінги, я нагадаю, були присвячені діям медичного персоналу у разі хімічної атаки, біологічної або радіаційної, і, власне, всім видам зброї масового ураження. Сьогодні ми поговоримо про дитячу травму. На жаль, події в Україні і далі розвиваються доволі трагічним чином, і як би нам цього не хотілося, ми будемо продовжувати збирати для вас досвід тих країн, які, на жаль, так само зустрілися із збройною агресією, в тому числі збройною агресією Росії, щодо мирного населення, і маємо на сьогодні дуже багато постраждалих дітей, яким потрібно надавати допомогу. So I pass the word to our Syrian colleagues. Thank you again for sharing your experience. Thank you for being so involved in the issue of war against Ukraine. I hope you are safe and your family are safe, and I hope that together we will defeat, the Russian aggression and Russians will be defeated by our mutual efforts. Here you go. Go ahead. Let us start.
Thank you, Medina. Today we want talking about a new subject about pediatric trauma. This is Dr. Abdullah and my colleague, Dr. Abdul Kahar Sayadi. Where is the mouse? Yeah. In this lecture, we want talking about pediatric trauma, our outline today. We will identify the anatomic and physiologic differences in children that account for unique pediatric injury patterns and demonstrate an understanding of special importance of managing the airway and restoring adequate tissue oxygenation in pediatric patients, and identify the quantitative vital signs for pediatric patients, demonstrate an understanding of management techniques for the various injuries found in pediatric patients, and describe the signs of pediatric trauma suggestive of non-accidental trauma. Okay. Okay, Dr. Abdul Kahar. Dr. Abdul Kahar, please.
Hello, how are you? My name is Abdul Kahar Sayadi. I am head of paramedic school in Academy of Health Sciences. Now I would talking about demography of pediatrics. The unique needs and characteristics of pediatric trauma or pediatric patients require special attention when assessing the actually injured child, the relative incidences of blunt versus penetrating trauma is highest in the pediatric population, with penetrating trauma accounting for only 7.8% of injury while penetrating trauma often result in injury to one body system. Yeah. Blunt trauma mechanism have a greater probability for multi-system injury. Multi-system involvement is the rule rather than the exception in major pediatric trauma, although minimal external evidence of injury may be present. Potentially life-threatening internal injury may still exist and must be evaluated at an appropriate trauma center. Okay.
Okay, so, okay,
Can you hear me?
yes, you can.
Okay.
Yes, it's all fine.
Yeah. The physics of trauma and the pediatric trauma. Child size produce a smaller target to which forces from fenders, bumpers, and falls are applied. Minimal cushioning from body fat increase elasticity for connective tissues and proximity of the physical to the surface of the body limit children. Ability to change these forces in the same manner and in the adult, therefore, energy is more readily transmitted to underlying organs. Additionally, the skeleton of the child incompletely classified contain multiple active growth centers and more resilient than that and others. As a result, there might be significant internal injury without obvious evidence of external trauma. Now we're talking about common patterns of injury. We have motor vehicle crash, child passenger, child pedestrian, fall from high, fall from bicycle, and explosions. Now we talk about in these points. Yeah. For understanding child multi-system trauma, including chest and abdomen, head and neck injury, scalp, and facial laceration. For restaurant child, chest and abdomen injury, lower spine fracture.
Hello?
We hear you, so you can continue.
Well, I think that they have lost the connection. I'm
Uh-huh.
sending them to check what's happening with them. Hello? Okay, so Mladin, how is the situation for today? I hope it's good.
We've just had a short air raid sirens in the western part of Ukraine, and it's been over about 5 minutes ago.
Oh my God.
Yeah, so I'm still sitting in the corridor
Oh my God.
in case it's getting
Um,
again.
I'm really sorry for that. Today in the morning, a Russian IRA, they attacked, a school and killed 4 children in the morning today. I don't know how they are thinking. They are criminals. Just they would like to take revenge from
Yeah.
people here, because here there is no, air defense. In Ukraine, there is air defense. There you have weapons to protect yourself. Here there are no weapons. For that reason, today 4 children were killed. Yeah, it's a bad situation, and we're praying for you.
Yeah. Is our screen?
We can see you. راح النت من عندكم بالكامل. We have lost
Okay.
it for a while.
Now you see screen?
Not yet.
Not yet. Yeah. Okay.
We see you, but not the screen.
1 minute, please. Where's now?
Yes, we can see the screen.
Okay, continue.
Okay. Yeah. Yes, continue. We talking about common pattern of injury. Now for medium energy, head and neck energy, upper and lower extremity fracture. For high energy, multi-system trauma, including chest and abdomen, head and neck injury, upper and lower extremity fractures. Without helmet, head and neck laceration, scalp and facial laceration, upper extremity fracture. With helmet, upper extremity fracture. Okay. Explosives are predominant causes of combat injury and death, and injury from explosion differ significantly from injury from other mechanisms. They are also more complex than those typically seen in civilian practice. What result from explosion? Explosion cause injury by multiple mechanisms, unlike fecular injury, blunt trauma, and injury from gunshot, which apply relatively simply mechanism to transfer energy to the human body. An explosion causes energy to be transferred. Energy to be transferred to complex and multiple functions. Energy from explosion is primarily designed to propel fragment, primary and secondary, at high velocity. Thus, the most significant cause of injury and multiple fragment wounds. However, primary blast over pressure, wool or partial body translation, injury from building collapse, including crutch injury, and injury from fireball and dust inhalation can all play a part of complex anatomy and physiology dysfunction. The ratio between a child body surface area and body mass of highest at birth and dimension. Hello?
Yes, keep. Hello.
Yeah.
talking. It's fine.
It's okay. Keep talking.
Yeah, the ratio between a chilled body surface and area and body mass highest at birth and diminishes throughout infancy and childhood. Consequently, more surface area exists through which heat can be quickly lost, not only providing additional stress to the child, but also altering the child's physiological response to metabolic derangement and shock. Profound hypothermia can result in severe coagulopathy and potentially irreversible cardiovascular collapse. In addition, many of the clinical signs of hypothermia are similar those in impending decompensated shock, thereby potentially muddying the pre-hospital care provider clinical assessment. The final outcome for injured child may be determined by the quality of care rendered in the first moment following an injury during this critical period. A coordinated systemic primary service is the best strategy to avoid unnecessary morbidity and prevent overlooking about potentially fatal injury, as in the adult patient, in the three most common causes of immediate death in the child are hypoxia or hemorrhage, massive hemorrhage, and overwhelming central nervous system trauma. Emergency treatment and transport to the most appropriate center for treatment can optimize the potential for meaningful recovery. Hypoxia, confirming the child has an open and functioning airway, doesn't preclude the need the supplemental oxygen and assisted ventilation, especially when central nerve system injury, hypoventilation, or hypoperfusion is present. Will appearing injured children can rapidly deteriorate from mild tachypnea to a state of total exhaustion and apnea. Once an airway is established, the rate and depth in ventilation should be carefully evaluated to confirm adequate ventilation. Yeah, the effect of even brief or short hypoxia on the traumatically injured brain deserves special attention. A child might have significant alteration in level of consciousness, yet retain an excellent potential from complete functional recovery if cerebral hypoxia is avoided. Pediatric patients who require aggressive airway management should be pre-oxygenated before attempting to place an advanced airway device. This simple maneuver may not only begin the reversal of existing hypoxia, but also provide sufficient reservoir to improve the margin of safety when placement and advanced airway is performed. Now we're talking about hemorrhage. Actually, most pediatric injury don't cause immediate exsanguining. However, children who sustain injury, the result in the major blood loss frequently die without moment of the injury or shortly after arrival at the recovering facility. This fatalities frequently result from multiple injury internal organs, with at least one significant injury causing acute blood loss. This bleeding may be minor, such as a simple laceration or contusion, or may be life-threatening hemorrhage, such as rupture spleen, laceration liver, or avulsed kidney. Furthermore, the pre-hospital care provider must be close attention to signs of ineffective organ perfusion, as evidenced by alternation in respiratory effort decreased, and diminished skin perfusion, decreased temperature, poor color, and prolonged capillary refill time. A major reason for the rapid transition to decompensated shock is the loss of the blood cells and their corresponding oxygen carrying capacity, restoring for the lost interval volume with crystal isolation will provide a transient increase in blood pressure. However, once vascular access has been secured, there is tendency in eventually over-resuscitation, and injury include child who child is not in frank shock, in the child with moderate bleeding, no evidence of end organ hypoperfusion, and normal vital sign. Fluid resuscitation should be limited to no more than 1 or 2 normal saline of 20 milliliter al kilogram per kilogram, and the child with the TBI fluid resuscitation should be given to prevent hypotension. Unknown and preventable contributor to secondary head injury, although over-resuscitation should be avoided to prevent an heterogenic cerebral edema. Hypotension must be prevented or quickly treated with the fluid resuscitation, as a single episode of hypotension can increase mortality by as much as 150%. Isotonic crystallite solution should be the fluid of choice for resuscitation for the child with TBI, because hypotonic crystal solution, dextrose and water, are now the increased cerebral edema further, although hypotonic crystallite solution, example, hypertonic saline, may be useful for treatment the cerebral edema in the pediatric intensive care, with where there is extensive monitoring. Central nerve system injury. The pathophysiologic change after CNS trauma begin within minutes. Early and adequate resuscitation is the key to increase survival of children with CNS trauma. Although some CNS injury are overwhelming fatal, many children with the appearance of advancing neurologic energy, go on the complete and functional recovery after deliberate. Coordinate effort to prevent secondary injury. This recovery are achieved through the prevention of suspicion episode to hypoperfusion, ventilation and adequate ventilation and oxygenation, while avoiding hypoperfusion is critical in the management of TBI, as avoidance, hypotension, a history of loss of consciousness is one of the most important prognostic indicator of potential serious injury and should be recorded for every case. Carrasco coma scale in this image modified for pediatrics. We are A, opening or papillary reaction, best motor response or response to sensory stimulation, or best verbal response or motor function. These are essential steps in the initial pediatric trauma assessment for neurologic energy. The absence of inadequate baseline assessment make ongoing follow-up and evaluation of intervention extremely difficult. Is now Dr. Abdullah will continue.
Yeah. Hello again. Thank you, my colleague Dr. Abdullah. Maybe fasting we are in Ramadan, as you know. Maybe fasting good for us.
Yeah.
Yeah, for assessment, the children or pediatric patient, we have two stages. We have primary survey and secondary survey. Actually, effective pediatric trauma resuscitation mandates the availability of appropriately sized airway. Laryngoscope blade is the pointer work, Mustafa? Laryngoscope blade.
Yes, it works. Yes,
Okay, endotracheal tube ET, nasogastric tube, a blood pressure cuff, oxygen mask, bag mask device, BVM, and associated equipment. Attempting to place an overly large intravenous IV catheter or appropriately sized airway can do more harm than good, not only because of the potential physical damage to patient, but also because it may delay transport to the appropriate facility. As you see here, the MPA, nasopharyngeal airway for pediatric. The three components of pediatric assessment, we have three components: triangle, appearance, breathing, how working of this breath, and circulation to the skin. So three components: appearance, breathing, and circulation. The first step is to use TICLS, mnemonic to assess the child's overall general appearance. Tune, tune, move spontaneously, resist examination, sits or stand. This is related to age appropriate. Interactive is the child alert and engaged with a clinician or caregiver, interacts with people and environment, reach to the toys, objects, example, pen light, etc. Consolability has differential response to caregiver versus examiner. For look, gaze, make eye contact with the clinician, tracks visually. For speech or cry, if I have a strong cry or uses age-appropriate speech. For breathing, listening for abnormal airway sounds. For circulation, assist the circulation to the skin by looking for pallor, mottling, cyanosis. This is Steve for airway listening. As I told you, for any abnormal airway sounds and looking for abnormal positioning, reactions, nasal flaring. For circulation, if I have a pallor or cyanotic skin, for stabilization priorities, survival rate from immediate exsanguinating injury is low in the pediatric population. The initial priority is to identify any exsanguinating external hemorrhage and control the bleeding by direct manual pressure. As you know, the most effective manner for stop bleeding is direct pressure, even in operation room. Direct pressure is more effective from any manner. Once exsanguinating hemorrhage has been addressed, or if not present, the provider should manage the pediatric airway. Here, we must check airway, breathing, circulation. If we have exsanguinating bleeding, we must stop the hemorrhage, then go to A phase mean airway. For A, as in the injured adult, the immediate priority and focus on the acute injured child are on airway management. There are anatomic differences that complicate the care of the injured child because the children have a relatively large occiput and tongue and have an anteriorly positioned airway. As you see in this picture, large occiput and large tongue, and the positioning of airway is for anterior. Additionally, the smaller the child, the greater the size discrepancy between the cranium and the mid-face. Therefore, the relatively large occiput forces passive flexion of the cervical spine. Okay. In the absence of trauma, the pediatric patient airway is best protected by slightly superior anterior position of the mid-face, known as sniffing position. Okay. In the presence of a trauma, however, the neutral position best protects the cervical spine by keeping it immobilized to prevent flexion at the 5th or 6th cervical vertebra. And the extension at C1 to C2 that occur while the sniffing position. Okay. In this position, jaw thrust maneuver can be used to facilitate airway opening if needed by jaw thrust. Additionally, placing a bag or blanket about 2 to 3 centimeters in thickness under infant torso can lessen the acute flexion of the neck and help keep the airway patent. Okay. For BVM, bag valve mask, the ventilation with high flow, 100%, at least 15 liters per minute. Oxygen probably represent the best choice when the injured child requires assisted ventilation. If the child unconscious, oropharyngeal airway may be considered, but due to risk of sometimes vomiting, it should not. If the pre-unconscious, actually here we're talking about pre-unconscious. If in the children in this phase, you should not be used the oropharyngeal airway because the child have intact gag reflex. This is also true of the laryngeal mask, okay, and King LT if the patient unconscious. King LT, laryngeal mask airway, maybe or any other kind of supraglottic airway. Actually, endotracheal intubation, despite being the most reliable means of ventilation in the child with airway compromise, should be reserved for those situations in which bag mask ventilation is ineffective. Nasotracheal intubation is not recommended in children. This technique requires spontaneously breathing patient, involve blind passage around relatively acute posterior nasopharyngeal angle and can cause more severe bleeding in children. Additionally, in the patient with a basilar skull fracture, it can inadvertently penetrate the cranial volute. If we have a basilar skull fracture, the NPA is contraindication. Okay. If unable to receive effective bag mask ventilation, a child with craniofacial injury causing upper airway obstruction. Okay, a child with craniofacial injury causing upper airway obstruction. This lead to maybe percutaneous transtracheal jet ventilation with a large angiocatheter, as you see here in this picture. This procedure is only a temporary measure to improve oxygenation and does not provide adequate ventilation. Increasing hypercarbia that a more definitive airway be established as soon as safely possible. For surgical cricothyroidotomy is usually not indicated in the care of the pediatric trauma patient, so if may be considered in the large child, usually I think to 12 years. For breathing, as in all trauma patients, significantly traumatized, a child typically need oxygen concentration 100%, at least 85%. This concentration is maintained by the use of supplemental oxygen and appropriately sized clear plastic pediatric mask. Evaluation of the child's ventilatory status with early recognition of the signs of distress and the provision of ventilatory assistance are key elements in the management of the pediatric trauma patient. Actually, the normal ventilatory rate of infants and children younger than 4 years is typically 2 to 3 times that of adults. Okay, actually the breathing resuscitation for children is 3 to 5 breathe, 3 to 5 seconds, one breath. For infant, 1 to 3 seconds, one breath. What are the effectiveness signs of ventilation and oxygenation, or what the indicators for a good breathing? Actually, we have many criteria for breathing. You know, when we give breathing, we have rate and depth. Rate and depth called minute volume, and effort indicate adequacy of ventilation. Pink skin may indicate adequate ventilation. Dusky, gray, cyanotic, mottled skin indicate insufficient oxygenation and perfusion. Anxiety, restlessness, and combativeness can be early sign of hypoxia. Anxiety, restlessness, combativeness, early sign of hypoxia. Lethargy, depressed level of consciousness, and unconsciousness are probably advanced sign of hypoxia. Brief sounds indicate the depth of exchange the air. Wheezing, rales, or ronchi may indicate inefficient oxygenation. Declining pulse oximetry and or declining capnography indicate respiratory failure. After stopping any exsanguinating hemorrhage, ensure adequate airway patency and breathing, then proceed to a circulatory assessment. The child heart rate should be assessed and identified as tachycardiac, heart beating too quickly, normal or bradycardia. If the child is bradycardic, go back and assess the airway. Okay, for normal or fast heart rate, look for signs of hypoperfusion. Hypoperfusion, pallor, mottling, poor capillary refilling time. Hypotension is a late sign of hypovolemia. A child with hemorrhagic injury can maintain adequate circulating volume by increasing peripheral vascular resistance to maintain main arterial pressure, MAP. As you know, main arterial pressure. Clinical evidence of this compensatory mechanism includes prolonged capillary refill time. As you know, the normal capillary refill time less than 2 seconds. Peripheral pallor or mottling, cool peripheral skin temperature, and decreased intensity of the peripheral pulses. In child, signs of significant hypotension develop with the loss of approximately 30% of the circulation volume. For disability, we have a VPU scale, A for alert, alert and bleeding, V response to verbal stimulus, P response to painful stimulus, or at the end, if we have no any stimulus, this child is unresponsive. Go to check the pulse for children, brachial pulse. If no pulse, start CPR. Now, this is for disability. For E, expose and environment, we must examine for this children for other potentially life-threatening injuries. While exposure, we have a critical and necessary to identify injuries. A child may be frightened and attempts to remove his or her clothes. We must explain our procedure to expose each area and have a parent present whenever possible, because in addition to that, because the children have high body surface area, we afraid from developing hypothermia. Once the examination to identify other injuries is complete, the pediatric patient should be covered to preserve body heat and prevent further heat loss. The secondary survey of pediatric patients should follow primary survey only after life-threatening conditions. Okay, we identify the life-threatening conditions and manage it, then go to secondary survey. The head and neck should be examined for obvious deformities, contusion, abrasion, puncture, burns, etc. You know, lacerations, swelling, etc. The thorax should be re-examined. Potential pulmonary contusion may become evident after volume resuscitation, manifested by respiratory distress or abnormal lung sounds. Trauma patients are infrequently NPOs, NPO, at the time of their injuries. So insertion, nasogastric or gastric tube may be indicated if local protocol allow for this procedure. For TBI, traumatic brain injury, the result of the initial neurologic assessment are useful for prognosis. Even with a normal initial neurologic evaluation, any child who sustained a significant head injury may be susceptible to cerebral edema, hypoperfusion, and secondary insults. Furthermore, victims of non-accidental trauma may have little external evidence of a trauma, yet may have sustained considerable intracranial injury. A baseline Glasgow Coma Scale score should be assessed and frequently repeated during transport. Supplemental oxygen should be administered, and if possible, pulse oximetry should be monitored. If we have traumatic brain injury with hypoxia or hypovolemia, it's dramatically worsen the original TBI. External hemorrhage must be controlled and the child's fractured extremities embolized to limit internal blood loss associated with this injury. As you know, the perfusion of the brain depends on cerebroperfusion pressure. Cerebroperfusion pressure equal mean arterial pressure minus intracranial pressure. If the intracranial pressure increased, the cerebral perfusion pressure will decrease. If we have hypovolemia from another injury, maybe internal or fractures for extremity, and we have bleeding in this patient, this is worsened for the brain, the cerebral perfusion pressure. An attempt should made to keep the pediatric patient in evolemic state with IV volume resuscitation. On rare occasions, infant younger than 6 months of age may become hypovolemic as a result of intracranial bleeding because they have open cranial sutures and fontanelles. An infant with an open fontanelle may better tolerate an expanding intracranial hematoma and thus not become symptomatic until rapid expansion occurs. This is very important for children. An infant with a bulging fontanelle should be considered to have a more severe TBI. For children with gastrocoma care of 8 or less, adequate oxygenation and ventilation should be goal at all times, not to placement of an ET tube. You know the rule, intubate at 8. Here, we must give adequate oxygenation and ventilation. This is our goal all times, not only intubate. Prolonged attempt of securing endotracheal airway may increase periods of hypoxia and delay transport to the appropriate facility. The best airway for pediatric patient is the one that is both safe and most effective for this patient. Pediatric patient with signs and symptoms of intracranial hypertension, such as sluggishly reactive or non-reactive pupil, systemic hypertension, bradycardia, you know, this Cushing phenomenon. We called Cushing phenomenon, high blood pressure and bradycardia, abnormal breathing patterns. Sluggishly reactive, non-reactive pupil, systemic hypertension, bradycardia, abnormal breathing patterns may benefit from temporary mild ventilation to lower intracranial pressure. This signs may indicate to hernia, to brain hernia, to tentorium hernia in the brain. However, this effective of hyperventilation is transient and also decrease overall oxygen delivery to the CNS. As you know, the CO2 dilate the brain blood vessels. Okay, if we have hypoventilation, that's mean increase CO2 in the bloodstream, then dilate the vessels and the flow of blood, and versus if we have hyperventilation. Hyperventilation mean the CO2 reduce in the bloodstream and the brain blood vessel constrict, and we go to hypoxia and hypoperfusion. In this case, if we have the signs of hernia, hyperventilation may be good for patient in this moment. However, this effect of hyperventilation is transient and also decreases overall oxygen delivery to the CNS, actually causing additional secondary brain injury. It's strongly recommended that this strategy not be used unless the child is exhibiting signs of active herniation, as we told. During prolonged transports, small doses of mannitol, about 0.5 to 1 gram per kilogram body weight, or hypertonic saline, may benefit for pediatric patients with evidence of intracranial hypertension. However, the use of mannitol in the setting or insufficient volume resuscitation may result in hypovolemia and worsen shock. The indication for spinal immobilization in pediatric patient is based on the mechanism of injury, MOI, and physical findings, the presence of other injuries that suggest violent or sudden movement of the head, neck, or torso. If we have any evidence, any signs of spine injury, such as deformity, pain, or neurologic deficit. If we have any signs of this, we have spinal trauma for the pediatric. What are the management skills for spinal trauma in pediatric patient? As with adult patients, the correct pre-hospital management of a suspected spinal injury is inline manual stabilization, followed by the use of probably fitting cervical collar, and immobilization of the pediatric patient to an appropriate device so that the head, neck, torso, pelvis, and legs are maintained in a neutral inline position. When most small children are placed on a rigid surface, the relatively large size of the child's occiput will result in passive neck flexion. Maybe sufficient padding, 2 to 3 centimeters, about 1 inch, should be placed under the pediatric patient torso to elevate it and allow the head to be in neutral position. The padding should be continuous and flat from the shoulders to pelvis and extend to lateral margin of the torso and ensure that the thoracic, lumbar, and sacral spine are on a flat. Stable platform without the possibility of anterior posterior movement padding should also be placed between the lateral side of the pediatric patient and the edge of the board to ensure that no lateral movement occur when the board is moved, or if the pediatric patient and board need to be rotated to side, or of this to avoid aspiration during vomiting episodes. Thoracic injury, as you know, the extremely resilient rib cage of child often result in less injury to the bony structure of the thorax, but there is still risk to pulmonary injury. may be pulmonary contusion or pneumothorax or hemothorax. Although rib fracture are rare in childhood, but are associated with a high risk of intrathoracic injury when present. If we have cryptus, cryptus may be appreciated on examination, okay, and may be sign of pneumothorax. The risk of mortality increases with the number of fractures. The high index of suspicion is the key to identify these injuries. Every pediatric patient who sustained trauma to the chest and torso should be carefully monitored for signs of respiratory distress and shock. Abrasion or contusion over the pediatric patient torso after blunt force trauma may be the only clues to the caregiver that the child has suffered thoracic trauma. Additionally, when transporting a pediatric patient who has sustained a high impact blunt thoracic injury, the child's cardiac rhythm should be monitored en route to a medical facility. In all cases, the key items in managing thoracic trauma involve careful attention to ventilation, oxygenation, and timely transport to an appropriately facility. For abdominal injuries, the presence of blunt trauma to the abdomen or unstable pelvis, post-traumatic abdominal distension, rigidity, or tenderness, or otherwise unexplained shock can be associated with possible intra-abdominal hemorrhage. This is signs and symptoms for abdominal injuries. We repeat, tenderness may be abdominal distension, unstable pelvis, unexplained shock, maybe all of this possible to intra-abdominal hemorrhage. How to manage the abdominal injuries? The key in the pre-hospital, elements in management of abdominal injuries include fluid resuscitation. Why? To keep the MAP, main arterial pressure. Okay. Supplemental high concentration of oxygen to keep oxygenation. Rapid transport to appropriate facility with continual careful monitoring en route. There are really no definitive intervention in pre-hospital or in emergency room can we do to the pediatric patient, and as such there should be every effort to transport pediatric patient rapidly to the most appropriate facility because he needs surgery. The child caring for an injured child always poses significant physical and emotional challenges to caregiver, and these difficulties are amplified when caring for the pediatric patient with burns. The child with burns may have an edematous, swollen airway, and here we have a critical situation because we have probably airway obstruction. Yes, IV access may be complicated by burns of the extremity, and the pediatric patient may be hysterical from the pain. The primary survey should be followed as in other causes of pediatric trauma, but every steps of the primary survey may be more complicated than in a child without thermal injury. Most deaths related to structure fires are not directly related to soft tissue burn, but are secondary to smoke inhalation and swollen airway and asphyxia. Okay. When children are trapped in a structure fire, then often hide from the fire under beds or in clothes. These children frequently die, and their recovered bodies often have no burns. They die from carbon monoxide, CO, or hydrogen cyanide toxicity and hypoxia. Thermally induced edema of the airway is always concern in patient with burns. A pediatric patient with edematous airway may be sitting forward and drooling or complaining of hoarseness or voice change, as you see in this picture. These symptoms should be promote rapidly preparation for an intention of transport to the hospital. While en route, supplemental oxygen administered and preparation made for airway intervention should be symptoms progressive or the child develop respiratory or cardiac arrest. Okay. For management, supplemental oxygen must administer, and preparation made for airway intervention should be some symptoms progresses or the child develop respiratory or cardiac arrest. If an ET tube placed, okay, it need to be protected against inadvertent dislodgement or removal. If the pediatric patient accidentally becomes extubated, the caregiver may not be able to intubate the child again. This is for paramedics because we have progressive edema in the airway, and the result could be this arthros. After securing the airway and providing adequate ventilation, oxygenation, it's critical that venous access be obtained quickly. Children have a relatively small intravascular volume, and a delay in fluid resuscitation may lead to rapid development of hypovolemic shock. To provide a large volume of intravenous fluids require in critical burns, such as pediatric patients usually require 2 peripheral IV catheter to achieve the required IV flow. The insertion of a single large bore IV catheter is often challenging, so 2 catheter is all the more so. Burns on the extremities may make it difficult to impossible to establish enough access for an appropriate fluid resuscitation based on the percentage of body surface area burned. The volume of IV fluid need for resuscitation is determined. When peripheral venous access cannot be obtained, we have IO access. IO catheter should be used to an unstable or unconscious pediatric patient, although previously advocated only for pediatric patients younger than 3 years of age for IO access burns. IO infusion are now used in older children as well as for adults. How okay. Okay, thank you for listening. This
So we have some time for the questions, as I understand. The microphone. Would you turn on the microphone?
دكتور شغل المايك. اوكي.
Шановні глядачі, я прошу ставити питання. Якщо у вас є якісь питання, будь ласка, ставте їх під трансляцією в чаті, і ми будемо по можливості відповідати на них.
Okay, Mustafa.
Okay.
You hear me?
In the case, yeah, I hear
We
you.
are
In the
fasting now. We know Ramadan, and we have some.
Okay. So in the case, any questions? Then I'm going to, Doctor, I've got a short play. So Nadine, any questions?
Still waiting for some questions. Друзі, ми все ще очікуємо на питання. Якщо вони будуть, можете їх ставити в коментарях під трансляціями, і ми будемо їх озвучувати нашим лікарям.
I want to add information.
Well, up to now, there are no questions.
I think there are no questions, and yeah, we'll ask those who watches the translation if they'll have any additional questions. We'll gather that and send you.
Okay.
Thank you again for sharing the information. Thank you again for supporting Ukrainians and Ukraine. I hope the situation in Ukraine will get better soon, and we will welcome you here in Ukraine to have some offline trainings.
It will be our pleasure, of course.
It's our pleasure. Of course.
Я також хочу сказати нашим глядачам, що ми обов'язково зробимо переклад та викладемо всі матеріали, які сьогодні надавалися, і саме відео українською мовою. Тож очікуйте, будь ласка, на наші переклади. Це займає деякий час через наші обмежені технічні ресурси. Дякую всім за увагу. До наступних зустрічей на наших прямих ефірах. Thank you so much. We will translate all the materials that you have demonstrated and everything you've sent us. If you don't mind, I would like to have the presentation, the slides of today's lecture so we can translate it.
Okay, sure. I'm going to send it to you. It's okay.
Yeah, oh, of course.
And in the case there are any question, then you can send it to the group. I mean, offline.
Of course.
Then
Yeah.
Okay. Okay, thank you so much. See you. Bye-bye.
take care. Stay
Thank
safe.
you. Take care. Thank you.
Yeah.